All right, good morning, everyone. I'm Jared Klein. I'm a pediatric cardiologist at Joe DiMaggio Children's Hospital down the road, and we're going to talk about right-sided percutaneous valve procedures. So no disclosures other than I am an imaging specialist. I'm not an interventionalist, so I won't go as much into the valves aspect. And we've heard lots about the tricuspid valve today, but mine will only cover the pulmonary. So you didn't have to wait till next year. We heard a lot of good stuff. So objectives today, we're going to discuss indications, timing, and post-procedural management of percutaneous pulmonary valve placement. Normally I open my talks with, and now for something completely different. But odds are you are going to see some patients with a melody or a harmony valve in the pulmonic position. So it's not as different as I once thought. Now, one prime example is tetralogy of Fallot. This is the most common cyanotic heart lesion in pediatric cardiology, made up of an overriding aorta, a VSD, right ventricular hypertrophy, and then usually a dysplastic pulmonary valve and an RVOT hyperplasia. Repair might be able to spare the pulmonic valve, or it may not be salvageable. And in the case where it's not salvageable, they undergo what's known as a transannular patch. So there's no valve, and this results in to and fro flow. When flow comes back in diastole, your pulmonary valve acts as a backstop. If there's no valve, then there's no backstop. So here's an echo example of that. So you can see in this parasternal view here that the MPA, you see forward flow in the blue, and you see flow reversal there in the red. So there is severe pulmonic regurgitation in that case, and this is the pulse wave of that same thing. Now the RV and correction, the RV is actually very compliant. I always mess that up. So it's actually very compliant. So it will actually dilate like a balloon and will increase more and more and more in size. And you can see on this MRI that our RV here is bigger than our LV. Now, what other circumstances might an adult require a new pulmonary valve? Well, we talked about tetralogy of Fallot, but there are other flavors of TET with pulmonic atresia where there is no valve, truncus arteriosus where the pulmonary arteries are actually attached to the aorta, and cases of transposition with pulmonic stenosis. What all of these have in common is the surgical option is an RV to PA conduit. Now, conduits are usually from human cadavers, and they're good, but the problem is over time they can calcify and become stenotic, and as a result you get more RV pressure, which can result in RV failure. And the valves don't last forever, so then they'll also leak, and you'll have more RV volume and more RV failure as a result. And you could also get a mixed version of this. Now, as far as timing of percutaneous valve replacement, think of it as the Price is Right mountain climber. And I was very tempted to put the yodeling theme in here, but I knew everyone would get that stuck in their head and be very angry at me, so I did not do that. But you think of the mountain climber and the RV dilation as the mountain, and you keep watching the RV as it gets more dilated, more dilated, more dilated, and then at that last moment, you want to do a pulmonary valve replacement before the mountain climber falls off the mountain or the RV starts developing arrhythmias, RV dysfunction, heart failure, because it's a lot harder to reverse these. So you need to time pulmonary valve replacement accordingly. It's not an exact science, but you have to do your best. Now, the guidelines for this, the 2018 AHA/HEC values for adult congenital heart disease are very useful. It provides a lot of good algorithms, and I'll focus in on this diamond over here. You can say that an RV is really big, but it's better to have numbers that can back that up. Now, in pediatric and adult congenital cases, we do a lot of MRI testing, and what information can that provide? You can get an indexed RV end diastolic volume, and you can calculate RV systolic function, and this is the gold standard for both of these. However, you can also get other useful information that will help either in your surgical planning or cardiac catheterization planning. And here's some examples of that. So this is a 2D phase contrast example with post-processing, and you can see that this patient here has severe pulmonic regurgitation, and Dr. Little brought up 4D flow, and we do this in adult congenital heart disease as well, and you can calculate volumes using this as well. And this is an example here of how you, this is a short axis stack where you can calculate RV volumes. So you can see here that the indexed RV EDVI is, in this case, moderately dilated. So it can plan your surgery or procedure accordingly. Now, getting a CT is also very important because as you can see here with these 3D reconstructions, RVOTs are like snowflakes. Not any two are exactly alike. And that matters when you are deciding which valve to use. And there are different types of valves, which I don't have time really to go into today, but there are balloon expandable valves, and two of the most common are Melody valves and Sapien valves. And you also have self-expanding valves like the Harmony and the Altera. So a discussion with your cardiac cath doc is very useful in deciding which valve to use. And here's an example. So you can do a CT and send the data to Medtronic, who makes the Harmony valve, and they'll send you back simulations of what your valve will be in systole, where it will be in diastole, and also, importantly, its proximity to the coronary arteries. You don't want coronary artery compression. That isn't good. So that can decide whether you go to the cath lab versus whether you go to the OR. Now, as far as long-term outcomes go, we'll talk specifically about the Melody valve, and here's the source for that, which took 150 Melody valve patients, followed them out mostly for 10 years. The median was about 8.4, and the results are for here. So all-cause mortality was only 10%, and as far as reoperation, only 20% required that. Reintervention, 60%, and most didn't have more than trace pulmonic regurgitation, and NYHA heart stage improved all throughout. Now, I know yesterday we talked about your counseling of, say, the 20-year-old versus the 80-year-old. If you have the 20-year-old, you would have to say, well, we'll give you this valve. This isn't a one and done. Unfortunately, nothing lasts forever. So in the future, you may require another percutaneous valve, or you might require another surgery. Follow-up is very important. As opposed to, say, the 70 or the 80-year-old, that might be the one valve that they need for the rest of their life. Now, one complication that can result from percutaneous valve placement is endocarditis, and I show an example here of an infected Melody valve, and you can see two vegetations, what those arrows are pointing to there. So another study by McElhenney, which you can look up, they reviewed a lot of transcatheter pulmonary valve replacement patients, and about 10% developed endocarditis, and reasons behind this are still being investigated. So it was usually within about 3 years after that, and the highest risk factors were actually lesser age, and it's not positive why there's that association. Previous endocarditis episodes, if you had it once, you're more likely to have it again, and an increased pressure gradient. So when your cardiac cath doc implants, say, a Melody or a Sapien, it's very important to tell the patient, one, it's important for you to come back for follow-up care, but it's also very important that you maintain good dental hygiene because you are at increased risk for developing endocarditis. Now, as far as post-care goes, medication-wise, they'll be on high-dose aspirin for 6 months and then a baby aspirin for the rest of their life. And they are going to require endocarditis prophylaxis for the rest of their life as well. And, of course, the importance of good dental hygiene. Follow-ups usually 1 month after valve placement and then 6 months annually, but that can vary on the patient. And then imaging is very important. You can do echoes, more so as screening to look at valvular regurgitation and pulmonary stenosis. And then you can do further advanced imaging with MRI if you want to get an exact measurement of your RV, get another indexed RV volume. And if they need to go back to the cath lab, you can evaluate the valves via fluoroscopy as well. So, what did we learn today? So, it's important to delay pulmonary valve replacement as late as possible, but again, you don't want to fall off the mountain into arrhythmia or RV dysfunction range because those are very hard to reverse. Echocardiograms are great for screening, and MRIs are great for quantitative data to decide if your patient, an asymptomatic patient, needs a procedure or a new valve. The guidelines are important, the 2018 ones, and that's what we use. And you should discuss all your procedural candidates with your cardiac catheterization team and consider a CT for device placements. And these patients are going to require aspirin and endocarditis prophylaxis for life, and it is important that they receive lifelong cardiology care from an ACHD physician. And we have two at Joe DiMaggio Children's Hospital, Todd Roth, and Cleveland Clinic alumnus Josh Safe. I work very closely with both of them with the ACHD MRIs. So thank you very much for listening to my talk, and I hope you have a great rest of the conference.